Hello and welcome to this session. This is a gross picture of a heart which has been cut open in a postmortem specimen, and you can see that the left ventricle is enlarged and thickened. The ventricular wall is thickened so much that the chamber space has become very small. And if you can see, it is uniformly round and thickened. We call this concentric hypertrophy, and this occurs in left ventricular hypertrophy. The wall has hypertrophied so much that there is very little chamber space for the blood to be pushed through. In fact, there is very little chamber space for the blood to come into the ventricle. So when very little of blood comes, how do we expect this small amount of blood to be pushed out through the ventricle to the rest of the body and the body to function? Impossible, right? So the pathogenesis of heart failure leads to two aspects of hypertrophy, either a concentric hypertrophy or an eccentric hypertrophy. A concentric hypertrophy is where in a normal heart first there is pressure overload. The blood that goes into the left ventricle is pushed out of the left ventricle through the aorta. There is pressure in the peripheries, which means there is an increased peripheral resistance. The systolic pressure increases. So that causes a stress on the systolic wall. The heart muscle of the left ventricle wants to push out more at the same time, so the wall thickens. This results in concentric hypertrophy, and the best example is hypertension. In the second aspect, the blood that goes into the heart, left ventricle, is more than normal, so there's a volume overload. So there's an increased diastolic pressure, diastolic wall stress. So the heart wants to pump out more blood in during the ventricular systole because more blood is coming during diastole. So the chamber enlarges to accommodate and accept more blood, and that will cause dilation of the heart. This is called eccentric hypertrophy, and the best example is cardiomyopathy. Now, irrespective of whether it's concentric or eccentric hypertrophy, the muscle mass increases. But in the early stages of a heart failure, the ratio between the wall thickness and the cavity size is the same, is constant. In late stages, in concentric hypertrophy, the wall thickness increases and the cavity size decreases. And in eccentric, the wall thickness reduces and the cavity size increases. It's the other way. This is what I just explained in the previous slide. In concentric hypertrophy, the ratio between the wall thickness and the ventricular cavity size increases. Now, either in concentric hypertrophy or in eccentric hypertrophy, in the early few years when a person suffers from this disease, it is in a sort of a stable state, even though it is hyperfunctioning. But gradually, the myocardial function deteriorates, and that can lead to a heart failure. And now, at the stage when the myocardial function begins to deteriorate, the ventricle dilates. So the ratio between the thickness and the cavity size declines. So the myocardial fibers are in great stress to pump out the blood. And since they are in a stress to pump out more blood, the myocardial fibers can become weak and it dilates further. And this continues and a visual cycle sets in. So in the case of a forward failure, the left ventricle cannot pump out blood through the aorta. So in such cases, it is accompanied by congestion. That is, the left atrium undergoes a back pressure and it goes back to the lungs. Because the ventricle cannot push out the blood during that the ventricle gets during diastole. So the pressure on the left ventricle goes up to the left atrium, which falls back to the lungs. So the pressure in the left atrium will go as an end diastolic pressure in the heart and elevated venous pressure. So what is a forward failure will continue as a backward failure. Now, there are numerous hemodynamic alterations that occur during cardiac failure and that can worsen the cardiac failure also. A congestive heart failure will involve either the left ventricle and after the lungs, the right atrium and the right ventricle, or it can involve all the four chambers in course of time. So when the heart begins to fail, the heart wants to try to recover. When we fail in an exam, we try to study again to work hard to pass the exam. When we fail in any career or business, we try to work hard to bring up the business. The same thing with the heart. When it starts to fail, there are numerous adaptive responses. Now, these adaptive responses are the ones that I told you as neurohumoral reactants, neurohormones that are increased in chronic heart failure. Now, let me repeat a few common important neurohormones: norepinephrine, epinephrine, renin, both in the plasma and the tissue, angiotensin 2, aldosterone, prostaglandins, which are part of chemical mediators, vasopressin, VIP. I'm sure you know what VIP is: vasoactive intestinal peptides, natriuretic peptides, endothelin, endorphins, calcitonins, growth hormone, cortisol. All these are very important. These induce neurohumoral reactants. In other words, they're all switches in the body that awaken the body to make the heart pump out and beat out more to prevent the heart from failing. So, for example, norepinephrine and epinephrine act, and that will cause an increase in the sympathetic nervous system, and that will increase in the heart rate and force of contraction. Which means when there is a heart failure, all these physiological mechanisms are set into play to improve the hemodynamic circulation.